Welcome back, everyone. As people start filtering in, starting our last session this morning, Saturday. This morning will be focused on some pediatric topics. I'd like to introduce our first speaker, my colleague locally, Dr. Matt Cage from Tripler Army Medical Center. He'll speak on complication avoidance and routine adolescent idiopathic scoliosis surgery. Thank you.
All right, good morning. And like Kyle said, my name is Matt Cage. I'm an orthopedic spine surgeon over at Tripler here in Honolulu. All right, and so my talk is going to be on avoiding complications in routine adolescent idiopathic scoliosis surgery. I don't have any financial disclosures, and like was mentioned yesterday, it's really awesome to see how much this meeting has grown. So Lee, Kyle, thanks so much for the opportunity to talk again. So in preparing for this talk, I was reminded of a story that I had read in James Clear's New York Times bestselling book, Atomic Habits. The short version is that the British cycling team had been pretty terrible for the 100 years preceding 2003, which is kind of an anomaly for a Western European country. They'd only won one Olympic medal, and they'd never won the Tour de France. So they hired David Brailsford to be their performance leader. And the big difference between David and the previous leaders of the British cycling team was that he believed in this philosophy called the aggregation of marginal gains. And so the concept of this philosophy is that you would look for small areas of improvement in everything that you do, and then in the end, kind of add up everything and you would see significant performance improvement. So the team did several things like try on different fabrics for their racing suits. They put alcohol on the tires so they'd grip more. They painted the inside of the team truck white so they could spot dirt and dust that would affect the performance of these very expensive bicycles. And they even hired a surgeon to teach all the riders how to wash their hands so that they could avoid catching colds and train continuously. So within 5 years, they captured 60% of the cycling medals at the Beijing Olympics. 4 years later, they set 7 world records at the London Olympic Games. And since starting this system, they've won the Tour de France 6 times. So this talk is going to be about aggregating the margins. There's likely not going to be anything that I'm going to say that you haven't heard before, but it will be the implementation of many small changes that help us to avoid complications in routine adolescent idiopathic scoliosis. So we're going to focus on kind of 4 critical areas. So controlling surgical site infection, minimizing new neurologic deficits, minimizing implant and deformity-related complications, and then the utilization of spine-specific teams. Just real quickly to kind of define what I'm talking about for routine AIS, so 50 to 80 degree curves that are flexible, done through a posterior approach and a posterior spinal fusion. So AIS surgery is elective surgery, and in all elective surgeries, it's clear to define the risks and weigh that against the expected benefits. So in this thought-provoking study done by Lahner et al., published in 2021, it was shown that the parents of children with AIS have some misconceptions about the risks of surgery, specifically the ones that cause the most trepidation, so like death, implant malposition, and surgical site infection. So, in their study, the parents were given 4 series of pamphlets on each complication, followed by a questionnaire. And then each pamphlet had progressively more information regarding that complication. And then what we saw is that as the parents learned more about the complication rate, their risk aversion decreased and made them more likely to consent for their child to have a posterior spinal fusion for adolescent idiopathic scoliosis. And so this is a very important consideration because the literature suggests that delaying AIS surgery is not always going to be a benign thing. If you wait on AIS surgery, the curve patterns can change. You have more complications. The fusions get longer. The operative time gets longer. The blood loss goes up, and you can have more loss of correction, longer hospital stays, and increased cost. So what is the rate of complication in routine AIS surgery? Well, the most recent literature would suggest it's about 1.5%, and this was done with the SRS M&M database. They had 84,000 patients, and they showed that the most common cause of complication was surgical site infection, new neurologic deficit, and then implant-related complications. And probably the absolute numbers are not as important as like the relative proportions. The most interesting and maybe expected finding from the study was when they looked at the bookends of their data. So 2004 to 2007 and then 2013 to 2014, they saw a tremendous decrease in the rate of complication. And most of that was related to implant-related complications and new neurologic deficits. I put this slide in here just to show that there is some, relative ambiguity in the literature regarding the complication rate. And this obviously has to do with, who we're including in the study, how long these patients are being followed, and what is being considered a complication. All right, so moving on to surgical site infection, going back to that study with the 84,000 patients, surgical site infection is the most common complication. For AIS, it's most likely going to be a gram-positive organism. Because most patients are healthy, the risk factors for surgical site infection are most closely tied to the curve magnitude. There is some evidence to say that obesity does play a role, but that's somewhat controversial in that other papers have shown that it's not really playing a big role. Medical comorbidities in AIS surgery is really rare. And then intraoperative blood loss is tied to surgical site infection and is maybe something that we have some control over. So while the curve characteristics certainly govern blood loss to some degree, these are some of the things that we can do. This is a paper that I give all the residents who rotate on my spine surgeon service to read, and it gives mitigation strategies for preventing blood loss in AIS surgery. So kind of things that we all know and probably do in our own practice. You bolus the TXA, you run it throughout the case. You have permissive hypotension during the exposure. You use intraoperative cell saver, meticulous hemostasis and high electrocautery settings, watertight closure. And I think the use of drains has kind of shown that it may just increase your blood loss. So they talk about not using drains. One of the things that they didn't mention here is that I wanted to say was the importance of normothermia while performing these surgeries as well has an effect on your blood loss. There really isn't a best practice protocol for surgical site infection prevention in AIS surgery, but certainly there's published guidelines for high-risk pediatric surgery. So I think we can borrow from this list to aggregate the margins of our surgical site infection prevention. The ones that I think are most germane to AIS surgery are highlighted in red, using the pre-wash with chlorhexidine, educational materials given to patient families, using pre-op appropriate weight-based antibiotics, adherence to the redosing protocol, chlorhexidine skim prep, limiting OR traffic, wound irrigation at the end of the case, routine use of topical vancomycin, meticulous closure, and postoperative antibiotics with an occlusive dressing. So here's just an example of successful implementation. So this was from the Rainbow Babies Hospital in Cleveland. So they implemented a protocol. They looked at their data 2 years before and then 2 years after. They included two additional things that I hadn't mentioned before. They screened their patients for MRSA and then treated the carriers. And then they also instituted a glove changing protocol where they would change the gloves after the drape and before handling any metallic instruments. And so the study included a bunch of mixed etiologies, but they did break it down by etiology. On the far right, you can see there's their idiopathic group. And so before implementation of this protocol, they had an infection rate of 5.9%. And then in the 2 years after, they didn't have any infections. There's 251 pages in the pre-protocol group and 237 in the post-protocol group. All right, so moving on to new neurologic deficits. So probably the most important thing that you can do to minimize neurologic deficits is to respond appropriately to an intraoperative neuromonitoring change. In 2014, Vitale et al. Created a checklist for intraoperative neuromonitoring changes, which is an optimal, organized, thorough response to an intraoperative neurologic crisis. Likely, everyone in this room is familiar with this chart here, or has potentially lived through its use. Just two things that I would like to highlight. Number one is the first step, which is gaining control of the room. A lot of times in routine AS surgery, it's a relatively low stress environment. There might be music on in the room or side conversations with the trainees or the nurses or anesthesia. And so you want to stop all of that. And then the second thing is consultation with a colleague. So I can remember going to the SRS meeting in Montreal and sitting through a talk that the author of this paper was giving, and he was recalling an experience that he had in the OR where he had loss of intraoperative motors, went through the whole protocol, still had deficits. And so, he called over to the next room, which was Larry Linke's room, and Larry Linke came into his room and they troubleshooted the problem and saved the patient from a devastating neurologic injury. So, whether Larry Linke is going to come and save you or not, I do recommend calling a colleague when you're in these situations. The last thing that I'll say about neuromonitoring is just that a lot of people advocate for having this up in your OR as kind of like a poster. I'll be honest, at Tripler, we don't have it up in the OR, but I have the luxury of having a very good neuromonitoring staff. And so she keeps this taped to the inside of her binder. So however you want to have it in the OR, it's just a good idea to have it with you in the OR. So moving on to instrumentation and deformity-related complications. If you recall the SRS database study about with the 84,000 patients, implant-related complications are the third most common type of complication in routine AIS surgery. However, with advances in technology and techniques, it's also an area that we've seen the most improvement. So malpositioned screws in the thoracic spine potentially can injure the spinal cord, nerve roots, vessels, pleura, and dura, and despite high volume and surgeon experience, they still occur. And so in this 2018 study by Bauer et al., they demonstrated a low-dose intraoperative CT scan after screw placement, but before deformity correction was very cost-effective and an efficient way to prevent reoperation of malpositioned screws. A little bit about PJK and DJK. It's certainly much less commonly discussed in regard to AIS surgery. I guess mainly because you rarely need to reoperate on these problems. But given the importance of sagittal correction in adult spinal deformity surgery, there's certainly been a new focus on the sagittal plane in AIS surgery. So the risk of PJK is approximately 7% in routine AIS surgery. Risk factors include postoperative iatrogenic hypokyphosis, improper selection of the fusion level, screws at the UIV, and the disruption of the proximal soft tissues. And then your mitigation strategies will be the use of hooks at the UIV, preserving the soft tissue, the midline soft tissues at UIV and UIV -1, and then restoring thoracic kyphosis. For DJK, it's reported to have about a similar incidence, 7%. Risk factors include pre-existent hyperkyphosis, improper selection of the fusion level, and again, disruption of the capsule ligamentous tension band. And then prevention strategies, again, preserving the distal soft tissues at the LIV, and then not stopping your construct above or stopping it below the stable sagittal vertebrae. It's kind of my feeling that we're in an era where we're kind of in between eyeballing estimates for rod contour and then using pre-planning software for patient-specific rod contouring and osteotomies. This is just one example of many that are available. It utilizes pelvic parameters and machine learning to template your correction. So the last thing that I'll talk about is just so teams and the importance of teams. I mean, it's no secret that teams improve performance across a wide breadth of fields. This was kind of a landmark study in 2018 with Miyagi et al., where they implemented specialized pediatric spine surgery teams in their OR. And again, they compared their outcomes before and after implementation of this protocol. And what they found was they had less surgical site infections, shorter OR times, shorter hospital stays, less blood loss, fewer unplanned staged procedures. And this has now kind of been repeated over and over in the literature. Murgai et al. Showed that you could improve your OR efficiency by increasing the members of your surgical team to greater than 60% spine-specific dedicated nurses and techs. So not surprisingly, they had less surgical time and less non-surgical OR time when they had greater than 60% spine nurses and techs. And then in just this past year, Martin et al. Showed that having as little as 1 to 3 dedicated spine surgery team members could significantly increase your OR efficiency. So if you had a spine-specific nurse, your OR time was 15 minutes better. If you had a spine-specific surgical tech, your surgical time was 24 minutes better. And then if you had a spine-specific anesthesiologist, your anesthesia time was 6 minutes better. Okay, so in summary, to decrease the risk of complication in routine AAS surgery, we need to aggregate the margins. So adopt best practices for prevention of surgical site infection and blood loss. Have a plan for neuromonitoring alerts before they happen. Leverage technology to improve performance. And you need to have a team. Thank you.
Great talk, Matt. Quick question for you. You mentioned that, one of the slides you started to use the patient specific rod or pre-planned rods in the contouring. It's right now it's just only in the sagittal plane that they plan it. The coronal plane they haven't incorporated that. I think that's something they're working on for the near future. But what's your experience with just planning the sagittal part, and how is the predictive the construct you end up, the alignment you end up in the coronal plane with the sagittally planned rod?
Yeah. So one of the neat things about some of the software is that it utilizes machine learning, and it has an aggregate pool of data from all surgeries done, but it does kind of individualize it for individual surgeon performance. And so what I've kind of started doing is trying to over contour a bit, because obviously you're going to lose some, right? When you derotate the spine, you're going to lengthen the anterior column, and you're going to lose some of that kyphosis that you would predict that you would get just based on the osteotomy. So yeah, I haven't quite totally figured it out, but it's nice because you feed the data into this system, and then it kind of gives you information back, and then as hopefully as time goes on, you just keep improving sequentially.
In the rod diameter, do you use tapered or the single diameter rod in the material? Is it cobalt chrome or?
Yeah, I use 6.0 cobalt chrome, and I have used some of the Prevent stuff before. And my experience is that it's more rigid than one that you would bend yourself. So,
and then just quick question to piggyback on Lee's question. The rods are bent sagittally, but they're also, the length of them are planned to basically a perfect coronal correction. Have you adjusted the way that you plan the length of those rods based on what you expect to correct in the coronal plane? Right.
So when you basically get them there, you can plan to make them a bit longer, and that's my default is just to bend to make them one level longer, and I usually end up cutting them in the OR.
All right, great talk. You talked a little bit about teams approach. What about your thoughts on having 2 spine surgeons for cases? You guys?
Yeah, I mean, obviously I have a little bit of mixed feelings about that, because I work with surgical trainees. So, I think there is some detriment to their training experience if there's 2 attending surgeons. But I've also been lucky to be a part of some circumstances where it's 2 surgeons, like mission trips and things like that, and it's pretty awesome to see how the flow of work can go with 2 experienced attending. So for routine AIS, I guess I'm a little mixed.